All right. Good afternoon, and thank you for joining us. I'm Chelsea Sawyer, Office Specialist with the Office of Aging and the Disability Services. Today, I'm joined by some of my department colleagues, as well as leaders from the Maine Healthcare Association and Maine's Long-Term Ombudsman Program. We will start with some basic housekeeping and then get started on this call. The meeting is intended for nursing facility providers as well as their administrators, directors of nursing, and other members of their quality improvement teams to learn about the VBP portion of rate reform. You're welcome to drop your name, title, and facility you represent into the chat if you have not done so already. This meeting is being recorded, and the meeting, as well as the PowerPoint presentation, will be posted to our rate system reform website later this week. We will put the link to the web page in the chat. We have a lot to cover, but we've saved plenty of time at the end of the call for questions. We expect a lot of questions will be answered during the presentation, so please hold them until the end. When it's time for questions, please submit them to the Q&A function located at the bottom of your screen so that we don't miss any of your questions. Please avoid entering questions into the chat and only use the Q&A. Any questions that we don't get to today can be sent to an inbox that we will share at the end of the call. And with that, I will hand it over to Director Saucier.
Thank you, Chelsea, and welcome everybody. Really appreciate everybody taking the time to attend today. We learned recently that this is conflicting with another educational opportunity, so appreciate that so many of you were able to come and be with us to talk about quality today. If we could put the slides up.
One second, I'll get here. And then it'll just take me a second to get back to my controls.
Sure, and when you do, you can advance it to the next slide. Great. So today's meeting really kicks off quality initiatives that we have been planning with many of you as we have engaged in rate reform for nursing homes really over the last 2 years. And I'll go over a timeline in just a moment. But one of the things that really excites me about the new rate methodology is that it does have some strong quality components to it, and we want to tell you what those components are today. We're hoping that after today's call, you will have an understanding of how we got here and what the quality opportunities are and how they're going to progress over the next 3 years. And then in particular, we want to make sure you understand what's expected of nursing homes in this calendar year in order to share in a quality bonus pool for 2025 that we'll provide you some details on. So taking a look at the agenda, next slide. We'll introduce the QuEST partnership to you. Then we'll do some level setting on value-based purchasing and what it is. We will tell you what the first set of quality measures are that we are going to be looking at with you. And then we will provide more details on this calendar year's quality bonus pool and what you need to do in order to participate in that. And then we'll tell you more about a whole group of activities that are planned under the QuEST label, and we will allow time at the end for questions. So if you have any, please hang on to them, and we will get to you with our questions. So looking, next slide. QuEST stands for Quality, Excellence, Staffing, Teamwork, and Amanda is going to talk more about QuEST and the whole group of activities that is going to fit under it. In part, we wanted to be able to put a label on these activities so that you can easily recognize them. We anticipate being in touch with you a lot over the coming 3 years. And we want you to know that when you see something with the QuEST label, it's related to the value-based program in nursing homes, and something that you ought to pay attention to. And so more on QuEST later. QuEST and this set of activities has grown out of not only the rate setting work and the specific value-based programming features of the rate, but also we know that quality in large part stems from having a stable and consistent direct care staff, and that has been very hard since the pandemic, and we understand that. And so Maine Healthcare Association and the Ombudsman program agreed to engage in a staffing task force with us that started in August to look at strategies for reducing the use of contract staff. That discussion morphed into something larger. So as you'll hear later today, there really are three distinct sets of supports that we will be providing with our partners. And we're really, really glad to have those partners, because we understand that we can't increase quality on our own here in Augusta. It really takes a partnership with providers, with advocates, consumers, and so on. And so with that, I'd like to introduce our key partners in this QuEST and give them a chance to talk a little bit about this work from their perspective. Brenda?
Okay, so thank you. Good afternoon, everybody. We're really pleased about this initiative because it's focused on quality. As I understand it, it was a good process between the department and Maine Healthcare Association in planning it. I think it really focuses on what is most important. What I know that most of you know, throughout my career, staffing has been kind of a primary interest of our program. So we're really pleased that it focuses on staffing levels. This will help you in terms of retention, better quality of care, and hopefully the reduced use of agency staffing. The Ombudsman program has a grant that was given to us by the Bingham program. We'll be working with you on retention. We have a grant with Maine Healthcare Association that will focus on supporting new Mainers into coming into the workforce. And we're going to be looking for additional grants to support you around retention. So we're really excited about this work, particularly as it relates to staffing and the reduced use of agency staffing, which I know is so hard for all of you, so expensive, and really doesn't provide the level of care that you really have as a goal. So we're excited. Just finally, I'd say the collaboration, I think, is going to be key to bring everybody together, Maine Healthcare, the department, the Ombudsman program, and all of you to work together so that you're not feeling so alone and that you do have support in this effort. So we're really excited about it. So thank you so much. And we look forward to working with you.
Thank you, Brenda. And Angela?
Yes, good afternoon. Thank you, Paul. It's a pleasure to be here. I wanted to just share that Maine Healthcare Association supports a collaborative approach to quality improvement in our long-term care centers. I think we all want good quality care for our residents, care that ensures safety and well-being, but care that's also resident-directed and patient-centered. We advocated strongly that the value-based payment program included in the new nursing home rate model would truly be a quality bonus pool, and that's what it is for year one, and you're going to learn more about that today. We're also very grateful for the legislature's support of the NIF Transition Fund, which is going to make these opportunities possible. MHCA supports this phased-in approach to meeting quality goals, and today you're going to learn more about year one and payment for participation. Lastly, this morning, I was reflecting to a colleague. I think the kickoff meeting, Paul, was about 2 years ago in February of 2023, when we all sat down with Guidehouse and started talking about, what were the best things about the model that we wanted to preserve and what do we want to change. So it's been a couple of years now. We're very grateful for the collaborative work and all those discussions with you, Paul, and your team at ODES, and also the DHHS staff, including Michelle Probert and Deputy Finance Commissioner Ben Mann, and of course, Molly Bogart, and many others in the department for meeting with us and talking about the needs of long-term care providers and our residents. Lastly, of course, we appreciate the ongoing collaboration with Brenda and her team at the Long-Term Care Ombudsman Program, and of course, this new QuEST partnership. So it's exciting to be here, and I'll turn it back to you. Thank you.
Thank you so much, Angela and Brenda. And you gave me a perfect segue, Angela, I'd like to talk next about just a sketch of how we got here over these 2 years. If we go to the next slide. As Angela just noted, it was February 2023 when we formally launched our rate study of Maine's nursing homes. And, you know, in past years and for many years, Maine had the same basic rate methodology. And so these rate studies were just basically updating based on the costs of the past couple of years. But we certainly wanted to do more, and we found that there was an appetite among other interest holders, many of you, to do something different. It was very clear as we all struggled through the pandemic with supplemental payments, et cetera, that the system was not working. We were losing nursing homes. So we really wanted to design something that places a strong emphasis and value on direct care, improves quality, increases the predictability of revenue for all of you, because we recognize that you can't keep the doors open without money, and results in a sustainable sector. So not one where we're just anticipating losing another nursing home. We know that we need the nursing homes that we have. And so that work was, of course, nursing homes were being debated mightily in this period, given the pandemic and how hard nursing homes had been hit. And so we had the advantage of lots of new thinking and literature, local experts and national experts, including the 2022 NASM report, that's National Academies of Science, something and Medicine, Engineering, Science, Engineering, and Medicine. And we've got the link there when you get the slides. If you haven't already taken a look, you can. You'll see that many of the features of Maine's new rate setting approach were recommended in that NASM report. And so a little over a year later, we released the draft rate model. It's based on 4.4 hours per resident day, which you will all recognize as considerably higher than state and federal minimums, but we think that that's really important and critical. And it includes value-based payment, which in the March edition was funded through withholds. Angela described the feedback that MHCA provided about that, and many of you did as well, that you were looking for a true bonus pool. There were also incentives to reduce contract staffing. We got many, many comments, so thanks to you who participated in that process. Next slide. In April of that same year, the legislature appropriated additional funds, and the department had proposed some additional funds because we had a better sense of what this would cost. And the transition fund was also proposed, and Angela mentioned that as well. That really gives us a luxury here to do a phase-in, to do some experimentation and some piloting of certain concepts. In August, I already mentioned, we started the staffing task force with LitCop and MHCA. And in October, after going through all of those comments and many discussions with MHCA, we released our final rate model. It includes the quality withhold, but it's phased in, so no withhold in this first year. And it includes a 3-year quality bonus pool. You'll learn more about that in just a minute. That is created with some of the transition fund money. Now, the new rates went live this month for the January billing period. As you all know, we did that under an emergency rule so that we could start it on the timeline that we wanted to start it. The regular rule that must follow any emergency rule was just noticed today. We will, I'll put in the chat, if you missed the main care bulletin on this today, it gives you all the information you need, including links, etc. I want to just note a couple of important dates for you. But again, this will all be in the bulletin that I'm going to link in the chat here in a minute. There's going to be a public hearing on March 10th on the proposed rule at 1 o'clock. It'll be in person in Augusta or via Zoom. And comments on the proposed rule are going to be due on March 27th. Oh, look at that. Somebody already did it for me. So there you go. Thank you, Karen. With that, I want to turn it over to Olivia to get into the content of the day.
Great. Thank you, Paul. Good to see everyone. I'm Olivia Alford. I work at Main Care, and I'm the Associate Director for Delivery System Reform. And we've been one of the people working on this rate reform for several years. And I have to say, as we go into the next slide and talk about value-based purchasing and the quality component that we're here to talk about today, I do have to reiterate that I think we have a really good structure set up here in the transition fund, the quality bonus pool, but also just the fact that there was such a good coming together that you'll hear about throughout this presentation of different partners, interested stakeholders talking about what's meaningful for quality and value within a nursing home setting. And I think we've landed on a really nice focus. So I'm excited to roll it out to you all. Some of it may be new to folks who haven't been in the previous conversations. So what we're doing today is just to be really specific about this quality component of the reimbursement. And then again, what is expected in year one, so that you can start planning for that. We're already in already in February for 2025 somehow. Next slide. So when we talk about value-based purchasing, we're talking about value. And when value is really the relationship between quality and cost. The way that you can impact value varies based on whether you're going to change both quality and cost or one or the other. And in this scenario that we're in for nursing homes, we're talking about an investment on the cost side. We're talking about, there's been an increase in our investment to support nursing facility service reimbursement under Main Care. So what we're looking to do is to combine that with focusing on an increase in quality at the same time, so we can increase or maintain value for those dollars. And we have, again, a phased-in approach to do that. Next slide. So with any process that Main Care goes through to look at how to create greater value, or even just to do rate reform in general, we're always going to look at what's available and what's happening nationally. So it is interesting, and there is a link here, which is a great resource to look at from, I think it was 2 years ago now. There are a lot of nursing facility value-based purchasing programs nationwide, 30 different programs in over 24 states. And this resource kind of gives you a list of all of them, and you can go through the details of many methodologies. That to say, it's not a new concept. It is somewhat new in the last several decades to apply this concept to nursing facilities, but it wasn't something that we had to start from scratch on. We had a lot of different examples. We used some of the literature Paul already discussed to make sure that anything that we designed really aligned with the values and the evidence behind what creates high quality care. As part of Main Care rate reform, we always look to whether there is an opportunity to include a value-based purchasing alternative payment model within a rate change. And in this case, all of it's happening at once. You're getting a rate reform and you're getting value-based purchasing all at once. So it is a lot of change. So we take those national examples, the literature at large, and we apply very closely a local context lens to this. What matters to main parties? Where has there already been work and interest? What are our local statistics telling us about our own situation? What are partners telling us? And what are our priorities? And you've heard a lot about that from people who already spoke. So it's very much, wanting to weight heavily the importance of staffing. And then again, talk about some clinical outcomes that you'll hear about in the next part of the presentation. So all that together, next slide, has led us to the basic design of what we're we're now in for nursing facility value-based purchasing. There are really two components, and we're going to keep it pretty high level for this conversation because when you get into the weeds of the methodology, it does get a little bit more complicated, but it's not that complicated in year one. Year one, which is this year we're in, we're talking about really just a bonus pool of transition, $8.1 million of funding that's intended to support care delivery transformation efforts that you all at the nursing facility level are going to be partaking in, and it's going to give you some resources up front to invest in whatever it is needed in your facility to improve quality over the next 3+ years. Each of the next 3 years, there is that 8.1 additional funds being put into a value-based quality bonus pool. We're not going to talk so much today about the second row about withholds because again, they don't apply in year one. But just so you know that starting in 2026 and going into 2027, there will be a portion of routine and direct care rate components that are withheld and dispersed upon achievement of quality. So it puts a little bit at risk as far as quality achievement starting again next year, but you have this year to get your kind of our legs underneath us and go through this QuEST process to start. I will note that we've been talking about this transition fund and this transition period. It's a 3-year fund and a 3-year transition process at this point. So the quality bonus pool at this point in time does not extend into 2028 or year 4. That would need to be a separate appropriation for main care. And right now, the plan is for it to end at the end of 2027. Next slide. So I want to reiterate, the quality bonus pool is additional funds. We're going to phase in accountability and opportunity under the quality bonus pool. It aligns with some of the elements of importance that are within the reimbursement model itself. And it includes just 3 quality measures, which is really great because if you do look at the other state examples, one of the pitfalls of many other state examples and other models in general is that they try to do too much. So I really think we've got a really focused area here, which you'll hear more about from Brooke in a moment. My last slide is the next one. And so it just lays out again what those 3 years look like. What is the phased approach? Year one, Angela mentioned, is pay for participation. There are a set number of requirements that you would want to complete if you want to have your share of the quality bonus pool. And by your share, it means the number of Medicaid bed days of your facility out of the total number of Medicaid bed days for nursing facilities that have participated in the quality bonus pool for 2025. Going into year 2 and year 3, there is an expectation of meeting first minimum achievement and then later being rewarded for higher achievement, essentially within the disbursement of the $8.1 million. The methodology for those, again, gets a little bit complex, but essentially you'll see when we talk about performance measures, when we talk about how we're going to assess performance against national standards, that we're going to be looking to see folks meeting first a minimum level of quality achievement in 2026, and then opportunity again for folks to do better than just minimum and achieve national averages or state averages going forward. But again, we're not going to focus on 2026 and 2027 today. We're going to instead talk about how we got to 2025 and what's required in 2025. So with that, I'll hand it over to Brooke.
Thank you. So just testing, everyone can hear me. I'll look for a thumbs up. Awesome. I'm Brooke McNaughton. I use she, her pronouns, and I'm the main care quality manager. I've been working on this program and this approach for the last at least year, maybe a little bit of change. And it's grown really near and dear to my heart. So I'm really excited to be able to share with you our process and the outcomes today. And so what I'm going to be doing, we've been talking about the word quality a lot in this presentation. And so I want to be really distinct in how I'm using it. So I want to anchor what it is that we're talking about. So if you go to the next slide, this is going to look the same. It's the same graphic that Olivia used when we look at value-based programs. There's this direct correlation between quality and value. You increase quality, you're improving the value. And that's specifically the piece of the puzzle that I'm talking about. And we talk about quality as this like kind of larger idea of what's going well in a facility in healthcare. But how can you prove that something is going well? How can you prove that something is high quality? You need a way to measure it. And that's where I come in. That's where quality measures come in. So in healthcare, that can get a little bit tricky, but I think something that is really nice is that because most of you are familiar with Care Compare, the 5-star rating system, you already have a primer on or exposure to quality metrics or quality measures. So what I'm going to be doing is walking you through our process, because we did take an almost painstakingly holistic approach, an exhaustive approach to making sure we chose the best possible metrics for this program. And then, of course, what those end metrics are and how you can really succeed in being a quality champion in your facility. So next slide. So this is the process that we took. And this isn't something that you're going to be quizzed on. It's not something that is necessarily going to, I think what this does more than anything is understanding this will alleviate any concerns that these measures aren't the right ones. These measures are for sure what definitely we're not able to sift through the cracks. These are the ones that were selected for a really good reason. I'm going to walk you through those reasons. So from left to right, we went through a large brainstorm, both internal, external, with stakeholders, developed a long list, met it against some criteria, proposed the measures, and then went back to the stakeholders, got lots of feedback, lots of qualitative feedback. We got quantitative feedback. We ran the data, and then finally we had our measure selection. I'm going to walk you through these just a little bit more. Slide. And it all started with that initial brainstorm 2 years ago from the Innovation and Quality Advisory Council. And that ended up in what this really nice graphic is, where we know that we want to end up in this program, we want to end up with all of these pieces that are on the periphery: the stable, well-trained workforce, excellent clinical outcomes, safe, comfortable living spaces. But really what's at the center of it all is person-centered care. The people that we are ultimately serving are the beneficiaries, are the residents. These are the folks who are at the center of who we're trying to serve. So keeping this graphic in mind, right, this came out of the initial brainstorm. We developed a long list. Slide. Knowing that we wanted to orient our measures based on these values. So we knew that we would want maybe 3 or 4, like Olivia said. When you find that you have more than just a couple measures, it gets kind of diluted. It becomes a little more difficult to know that you're doing well, to get your bonus pool, to orient your efforts in the right direction. So we knew we wanted just 3 to 4 measures in the areas reflected in that graphic that we had from that 2023 conversation. So staffing levels, person-reported experience, and clinical or utilization outcomes. So we developed a long list from there. I'm not going to go through each of them, but it's on the next slide. This is a great reference to know that we did look at these all exhaustively and then some. But again, orienting around those 3 different areas: staffing levels, person-reported experience, clinical utilization outcomes. Go ahead and go to the next slide. We compared all of these against a set of criteria. This is just a short list of the criteria, but we knew that we needed a reliable data source. Olivia mentioned that we already have 2 existing data connections for the 3 measures we're using, which is excellent. No extra work on your part. We know that the measures need to be actionable. Is it something that you can even make a difference on your side of things? We want that to be the case. It needs to be evidence-based. These measures are rooted in evidence as something that matters to facilities, as matters to the patient, and matters to the payer. Relevant, of course, to the population served. Address areas of poor performance. So this was a big one. This is a big one where Maine as a whole and many of our facilities are not doing as well as perhaps the rest of the facilities in the nation. So we spent a lot of time determining, well, where are we falling short? And then also aligning with national, regional priorities. And this is where a lot of those stakeholder conversations came in, and we're really grateful for those. Slide. So we did get feedback, and we're really lucky to have reached qualitative saturation on the feedback that we received. And just quickly, we got lots of support. So it was largely supportive. It indicated a need for technical assistance, and that's where we are very meta. We're here right now performing the technical assistance, giving you the rollout, and Amanda's going to walk you through the rest of the assistance that we'll have for these quality metrics. And then we also received recommendations on the model itself, which were incorporated. And so finally, after we got all of this feedback and we looked at all the data and we compared it against criteria, we looked at other national programs, we came up with our final list of measures. So slide. So under the staffing levels bucket that we knew we wanted, we ended up with % staff turnover. And so when you go to Care Compare, this is the % of total nursing staff that stop working in a facility within a given year. Low turnover indicates that facilities generally retain their staff for longer periods of time, and it's preferred. So lower percentage is better. Under the patient experience of care, we are choosing and electing to use the QuEST survey. There's going to be a lot more information on that. But it is a survey specifically for residents and or families of residents. And then finally, under clinical or utilization measures, we have antipsychotic use. And so that is the percentage of long-stay residents who got an antipsychotic medication. Similar to staff turnover, lower percentages are better. And then we did throw in something for monitoring. So with all of the feedback we received, we understood that monitoring UTI rates, so the percentage of long-stay residents with a urinary tract infection, would be highly valuable. We're not ready to put it into the rate model just yet, but we do want to keep an eye on it. And so we're going to be including that in the reports that you receive, so you're able to keep an eye on it as well. So let's go ahead and go to the next slide. So the reports that you're going to be receiving, they're under construction currently. We're working with a really incredible vendor to create these reports, and they're something that you're going to be receiving on a quarterly basis to keep up to date with how your performance is comparing to your peers and the national performance over time. It's going to be inclusive of a cheat sheet for understanding the measures themselves, even though we know that there's national TA for these measures. We're using the same exact measures you get through like Care Compare. We want to make sure that you just have a one-stop shop for getting the information that you need. And slide. So finally, you're probably wondering, all right, well, if that's all like the background information, what is it that I actually need to do in this first year? And this is where the meat and potatoes of this call is really going. So what do you need to do in year one? That's right now, 2025. So number one, this is important. Identify a staff quality champion for each nursing facility. Now, it's possible you already have a quality champion. You may have it by a different name. It may be someone who is responsible for quality work in other payers or with other maybe initiatives that you have going on. But our requirements are that your quality champion needs to A, work at the facility, B, have responsibilities in their existing job that include promoting quality improvement, quality culture, right? They need to be able to have an impact there. And 3 is a member of the nursing facility's quality assurance and performance improvement team. And while a quality champion will typically have a clinical background, this is not required. Something to note, it's not on the slide, so this is something that we will touch on later, but let this just be a first exposure. When you do select a quality champion, you need to let us know. This is going to be the person we're liaising with. This is the person we're communicating with. And the way you can let us know is through a designated inbox that I believe someone's going to drop in the chat right now. And then again, we'll introduce it later on in the slides. Okay, so your quality champion, that's a really immediate lift that will help you get over most of the, I wouldn't go so far as to say hurdles, but most of the things that may be challenging to understand, they're going to be the person who helps you interpret it. And in addition, you're going to want them and others to participate in quality improvement initiatives like this one and the ones that we're going to be talking about in more detail. And these are going to be known as QuEST, which is, I think, a really fun acronym that was developed internally. Quality excellence staffing, and is it teamwork or training? Oh no, I'm on the spot and I forgot. What's the T? Someone save me.
Teamwork.
Teamwork. Okay, cool. It was the first one I went for. Okay, quality champion. We have the odes.nfquality@maine.gov in the chat. That's who you're identifying your quality champion to. And they need that criteria, and then you're participating in these initiatives. Slide. 2 more things for year one. Is that you need to contract with a QuEST vendor. So we mentioned QuEST as one of these 3 main quality metrics, the way that we're showing that quality exists in your facility, the way that we're measuring it. You need to contract with a vendor ahead of year 2, so that's happening within this next year. And they need to be able to meet the technical specifications for the QuEST survey. There's going to be designated TA on this, but you can also learn more by visiting their website. The second, the last piece, but the second piece of this slide is to meet with Maine's statewide state designated health information exchange. That's that HIE acronym, to explore how they can help support you. And I'm actually going to turn it over to them right now to Miss Delaney, who's going to walk you through a little bit more of what they can do for you and give you an exposure to HIN and the amazing things that they support.
Thanks, Brooke. Hi, everyone. My name is Lainey Patterson. I'm the manager of client engagement at Health InfoNet. I recognize many of you on the call. It's great to see you again. What Health InfoNet does, we're a nonprofit organization. We're a team of 22, 23 people. Health InfoNet's been designated by the state of Maine to operate Maine's statewide health information exchange. Brooke, I apologize. Do you know if there are slides that have been included in the presentation?
I was under the impression that we were going to let you share screen.
Okay. I can certainly do that. I don't have it up, so it might take me a second, but I'm certainly, for the sake of time, I might just start talking because I've been very familiar with this sort of presentation.
Sorry, I
Go
have
ahead.
it. If I can share for you. I'll
Certainly. Thank you. I apologize about that. So Health InfoNet, nonprofit organization designated to operate Maine's Health Information Exchange. It's a statewide exchange. We have connections from the tip top of Aroostook County all the way down to the bottom of York. We have approximately 85% of ambulatory sites connected, all health systems connected across the state. So, you know, you have your Maine Health, your Northern Lights, your Martins Point, et cetera. So those major health organizations and systems are connected and sharing data to the exchange. We have several behavioral health organizations connected and sharing data. And we have information from reference laboratories, other labs. We have state information from HEDL and medication information as well. Basically, what we do is we incorporate all of the information that we receive from participants of the exchange and put it in a centralized longitudinal health record. We provide our participants access to this longitudinal health record through our web-based clinical portal. And next slide. The web-based clinical portal is basically an electronic health record. It's view only, so anybody who's been authorized by their organization to access this information, you're able to go into a patient's record and you can see information that's going to be critical to their care in one place. So you don't have to dig into their record from one organization and then another organization. It's centralized. So as a patient in many organizations across the state of Maine, you can see that my Maine Health information is here and my Martins Point information is right below it. So this clinical portal, this this screenshot here is the clinical portal. You can see that it includes demographic information, allergies, prescriptions, and encounter and visit information. So this is what you would see as you log into Health InfoNet's clinical portal. And it's a really, really key in ensuring that you have that care coordination for patients and residents who are admitting into your organization. And also, if there's an event in care and they have to be transported to an emergency department or inpatient at the hospitals can then access your information as well. Next slide. Speaking of events in care, we also provide notification services. Notification services allow you and other care members of that patient or resident to be able to have either real-time or a daily notification of events in care. Some examples are on my screen here. If a patient, for instance, is admitted to the hospital, you can get a real-time email indicating that there was an event for a patient. It provides the Health InfoNet record number. You go into Health InfoNet and you can access their record and assess what sort of next steps might be needed to support the care coordination and the patient's, ongoing treatment plan. In addition, if there's additional events in care, you can get a daily wrap-up. So instead of real-time notifications, you would receive one email that has a list of the events that had happened during that day. You can also access all of the notifications that come to you in any given time in Health InfoNet's clinical portal in that notification dashboard. And next slide. Lastly, we also offer health analytics reporting platform. This is known as HARP. HARP is a service that is provided to anybody that participates and shares data with Health InfoNet. So many of you would qualify for this. HARP is kind of the meat of why I'm here today talking to you all about quality. we are able to take the information that you all provide us in the exchange and provide dashboards to speak to patients' risk of readmission to emergency departments or inpatient care settings. We can talk about chronic conditions that patients have, risk of developing those chronic conditions. Additionally, standard quality measurements. This platform has been created by Health InfoNet for the people in Maine and their needs and the providers that are giving care. So it is really specific for Maine patients and Maine residents. Some of you might be familiar with HARP. You might already be using it. And if not, that's okay too. Certainly come to me, let me know if you'd like to use it. But this is a really, really powerful tool. We've been able to get feedback from a lot of our participants that indicate that they've been able to reduce their readmission rate because they were able to identify patients who would have otherwise been admitted to the hospital. So super, super close to our heart. We really are happy about this product and we are excited for you all to experience it yourselves. And next slide. We do have education that comes as part of participation. Our manager of clinical education wasn't able to join me today, Nicole Fisher. We provide a number of different platforms in order for you all to understand how to use the exchange and the services that we provide, whether that be personal support. We have a vast selection of documentation to be able to support you if you are a little bit more of a read and kind of learn sort of person. There's also tutorials and webinars that we provide to you in our learning portal, which there are links in this slide as well. And I can certainly have this shared at the end of our call as well. And next slide. This right here is our support portal. These link out to the support portal based on what your needs are. If you are an established participant of Health InfoNet, the first QR code will link to our established portal, which means that you can submit a meeting request, a project request, etc., and it will come to us. I do understand that QR codes are only, most of the time mobile friendly. So if you do need this on your email, I can certainly provide these to you as well. They do link out. If you have the slides at the end of the call, you can click on the title and it will link there. The second QR code is for organizations who are not participating with Health InfoNet and are inquiring about Health InfoNet participation. So if you're interested and you'd like to talk with me, I'll be the one that supports those conversations. Certainly give this a little scan and submit your request either for a meeting or a formal request for participation. And next slide. And that's all I have for you today. Happy to answer any questions that you might have, and I'm really looking forward to working with you all.
Thanks a lot, Lainey. Appreciate it. And we did save a bunch of time at the end for questions. If I don't know, are you able to stay on? Perfect. Okay.
Absolutely.
Terrific. Mandy, can you put our PowerPoint back on?
Yes. Oh,
I think you may have to stop sharing first, Olivia.
Yeah, I'm trying to.
It's frozen.
Yeah.
It wouldn't be a Zoom call without technical difficulties.
It's quite funny, having worked for an organization that's focused on technical support, most of the time, these things happen to me, especially on call with clients. So
yeah,
sorry, everyone.
Because we love irony, right?
And I just wanted to clarify one thing before we go on, so again, just to go back to the year one requirements to make it super clear. The requirement for year one for you all will be to meet with Health InfoNet for an hour, whether you are existing already connected or not yet connected. And so either way, the requirement is going to be around that meeting because they'll get to go through your specific nursing facilities needs, goals, use cases, personnel, workflows, all the things, and they're really skilled at that. So like either way, whether you're existing or not yet connected, you'll be doing an hour meeting if you want to qualify for the bonus pool this year. Thanks.
Okay, perfect. Thanks, Olivia. Next slide. Okay, so now that you understand the measures, the question is, how can we support you? So the team, again, across our organizations, we've come up with 3 unique but complementary initiatives to support you and your team on your quest for quality. Each of these initiatives supports a specific element of VBP, and these calls will happen monthly. These calls, as well as your time with the Health Info Exchange, they all count as participation, like Olivia said, for what to do in year 1. So we came up with this acronym for a couple of reasons. To make it easy to remember, should be very super easy to communicate internally within your own nursing home community, as well as internally, with your externally with your partners. Also, who doesn't love a good acronym, right? So QuEST specifically was chosen because any quality improvement effort is always going to be a journey, right? Or a quest. So quality, everyone here today, we can all agree that we want the best quality we can possibly deliver for Maine's nursing home residents. You wouldn't be in the business you're in if you didn't really care. Excellence, Maine is and always has been a leader. We strive for excellence in all we do. That's part of the pride of being a Mainer, right? Staffing. So we're really striving through that for staffing stability, because we know we can't achieve quality improvement without our team's support. Quality improvement is a process. It's not a one-man show. It really takes everyone. Teamwork, of course, within your facility, of course, this is all a heavy lift. You're going to need teamwork across your facility, but really across organizations too, right? We have a lot of providers here today, very engaged, and many partners who are very eager to support you on the journey. Next slide, please, Mandy. So each month we'll have one QuEST call. We'll rotate through each of the 3 initiatives. Today, you're learning about the whole program of QuEST, and you're also on the first call for making sense of VBP, one of the 3 prongs of the initiative. This one today is really to help you learn about the what, the when, the why. Later calls that you'll see on this slide are really designed to help you better understand the how. So this technical support, this is the nuts and bolts, right? These other 3 calls, these are definitely the dates. The topics are subject to potentially change. They might get the order of all 3 of these initiatives may change a bit based not only on speaker availability, but also just making sure that you get what you need in the order that you need it. We're trying to be very mindful of that. Additional office hours will also be scheduled, dates to be determined. We'll do a deeper dive on each of these for folks that need it. Brooke mentioned that a facility report card will help to kind of put all of that together. So this initiative, the leads on this are the folks who you just heard from, Brooke and Olivia. These are the initiatives the leads on this initiative. Next slide, please. So the Dementia Care Partnership, if you've been around for a hot minute, you may remember this because this is actually kind of bringing back all of the really great good stuff that nursing facilities used to do before everybody was majorly distracted by a global pandemic, right? And all of the trials and tribulations that come with it. So this one is designed to decrease the use of your antipsychotic medications, one of the 3 measures, right? But with a very strategic method in mind. So years ago, the Dementia Care Partnership was built by who I jokingly refer to as the 3 wise women, Holly Harmon, Margie McLaughlin, and Brenda Gallant, who we're lucky enough to have with us today. And the other 2 are always around supporting the state of Maine and all of these great initiatives that we're working on. So the lead for this one is Maureen Carland. Many of you are familiar with Mo. She's part of Maine Healthcare Association. Unfortunately, she was not able to join us today. But Ben is here in her place and has been very involved with all of this. So Ben or Brenda, I don't know if you wanted to say a few words about the Dementia Care Partnership.
Thanks, Amanda. I think your slide has a lot of the great details that folks should keep in mind moving forward for the next year. We're really excited to do the 2.0 version of this, if you will, for 2025. Just take note of those dates. We have our kickoff, and we'll also be talking about the first line of defense on March 26th. So that'll be one you certainly won't want to miss. I don't think I have anything else to add at this point. Looking forward to working with everyone on this. Brenda?
Right. So I think this is great to bring back this effort. We were very successful in prior years. We were leaders in the country. We achieved a 38.3% reduction in antipsychotics, and we did so many different interesting projects, music and memory, staff training and dementia care, a mentoring program. So I think the collaboration and the active involvement of so many providers was really critical to its success. So I look forward to it coming back, and I know we can do great things. And I think Maureen will do a super job in leadership, and we'll certainly support her in every way we can.
Thank you both so much. So as Brenda said, we've done it before. We can do it again. These are just the kind of pieces to help guide that initiative. Next slide, please. So the last leg of the stool, if you will, is the Culture Change Coalition. Again, rather than reinventing the wheel, this was another really successful initiative in years past. If for those of you that have been around for quite a while, this is kind of like a 2.0. It's a little bit different than how it was before. It's really going to be zeroed in on stabilizing staffing, decreasing nursing staff turnover, decreasing use of agency staff. Again, part of those VBP quality measures that we want you all to maximize. This is really built around the artifacts of Culture Change 2.0. These slides, as Chelsea mentioned, will be uploaded later this week. So all of these links work. So you're welcome to click on that link and look at it. It's a pretty expansive document, but it's very well valued and adopted in circles of culture change. So what we're going to do is we zero in on the leadership and team engagement portion, because to take on the entire document, maybe you're ready for that, or maybe that may be too daunting of a task. So each week each call, which we'll rotate through, will focus on a specific tenet from the culture change artifacts. For instance, direct care staff having input in scheduling and assignment. You may already be doing this. This may be something that you're already engaged in. Maybe you use a software app, or maybe the CNAs designate their assignment in a huddle, but as soon as they get there or something like that. Maybe it's ahead of time. So you very well may be somebody, if you're already doing this, that we may call on to speak as a local expert on the specific topic. Like I said, the initiative in its entirety covers a lot of ground. But the most important thing to focus on, and what we hear constantly from the national experts on culture change, like Holly Harmon of the American Healthcare Association, emphasizing that culture change is a journey. Many miles can be covered with lots of small steps. So we're taking it one bit at a time and seeing what we can do to actually put it into action. Next slide, please. So there are other resources available too. If you're not already signed up for OMS e-messages, you may want to do that. Some of you know we sent out an OMS e-message just to make sure if there was anybody that we missed in our original mailing, to kind of capture that. We make a lot of announcements that way for calls and things like that. The schedule of these QuEST calls won't come out through e-messages moving forward. We'll make sure that we have your quality champion and your administrator and director of nursing right on our list. So you can be expecting save the dates and invitations. And as we get closer to each meeting, an agenda on what we'll be covering on each of those calls. Another great resource that I think Mandy already dropped in the chat, but if she didn't, we can again, the Main Care Rate System Reform page. So after this call, you may be looking for the recording or the PowerPoint. Maybe you want to share this with more members of your team. That all lives right there, as well as all of the work previously that Paul and Angela alluded to that we've done over the last couple of years. So in addition to those quality calls, the QuEST calls, you want to look out for VBP office hours. So those will be additional supports as needed to really dig in a little bit deeper. Soon we will have a criteria and resources cheat sheet too, that talks about the requirements, the criteria that Olivia addressed before that you'll want to make sure to achieve in year one so that you can maximize your quality bonus payment. So we expect that to be coming pretty soon. It's in the final stages right now. If you don't already check out the Maine Healthcare Association education page, it's another great resource. They're really ramping up their education, and that's actually why Mo couldn't be here today. They're doing a really great leadership training series. So that's another good one to watch. The Direct Care and Support Professional Advisory Council, our ombudsman program is very heavily involved in that. That's a great way for your team to be very engaged, and it's really just for the direct care workforce. So having a CNA on that is really great representation for your facility and a great way to engage them. And then finally, any future questions that you have, email them to odes.nifquality@maine.gov. Karen was great enough to drop that in the chat also. So that's where you're going to want to send your quality champion to. And then if you have any sort of non-urgent questions that are just around quality in general, and we'll make sure that they get to the right person and they get addressed on upcoming calls. Like I said before, all of these links work. So when the PowerPoint is uploaded, you'll have a direct link to those too if you should decide to download it. And next slide, please. So that leaves us plenty of time for questions and discussion. We wanted to make sure that you all had an opportunity to ask your good question. So Chelsea, do you want to open it up?
Yeah, absolutely. So to ask a question aloud, raise your virtual hand. You'll see a react button at the bottom of the screen. Just hit raise hand. And if we have some of those of you that are joining by phone, press *9 to raise your hand and also lower your hand, as well as *6 to mute and unmute your line. You can also use the Q&A located at the bottom center of your screen to submit a question. Again, please just avoid using the chat to answer your questions so that they don't get missed.
Why don't we take down the slides so we can see folks, and don't be shy.
I don't see anything in the Q&A yet. Oh, one just popped up. How will our participation in these required areas be tracked? i.e., once I email ODES with our quality champion, how will I know that this has been accepted and we are all set in this area?
Yeah, I can answer that. So ODES will respond to your email acknowledging that it's been accepted. And so we're going to keep our tracking sheet on that one. You will see more detail like along those lines of questions. The proposed rule that is out will let you know kind of if there's a requirement for you to keep record versus this one. It's actually just going to be the department acknowledging that you've submitted that. So we won't talk too much about the rule specific language right now, but just to answer this direct question, we'll make sure that it's a good thing. We'll make sure to reply and say, got it. But on some of the other items you'll see in the rule language, it's a little more specific about where you might want to keep track yourselves too.
And your quality champion is really the primary person that we expect to show up to those QuEST calls. We'd love to have your administrator and your director of nursing and anybody else that you choose to include. That's wonderful, but we're really looking for consistency in that quality champion so that they can be a part of the conversation as it's evolving. Maybe your director of nursing or administrator is your quality champion, or maybe not. It's kind of a heavy lift. So if you have somebody else to, well, not too heavy of a lift. I mean, it's participation in the calls, but we know that directors of nursing and administrators often get pulled away.
There is another question in the chat, which I don't know if we want to wait for it to go through the Q&A, but I think it's for help. So maybe we can just make sure that Lainey is still, well, I'll answer it. It's just more of a process question. So the question was put in there around whether emergency facilities need to ask for participation, need to ask for Health InfoNet meetings via the website links in order to meet the requirements. I think I'll definitely let Lainey say like that I think that's the best way to request a meeting, but the requirement is about the meeting itself, not about how you request it. But Lainey, yeah, could you say more about like just the best way for someone to easily get that meeting on the books?
Yeah, absolutely. So I'm actually going to share in the chat some resources that I referenced during our presentation. It is not a requirement for you to put the request through our website. You can email client engagement directly or clinical education directly for this meeting. It is just easier for us to organize said request if you do it through our online portal, just because we're able to get as much information as possible about your availability, understand what you're requesting, etc. So I hope that answers the question. And if it doesn't, please let me know and I'm happy to provide more details.
And all of these resources, how to get in touch, how to get to that next step, like the Core Q website will be shared on that cheat sheet. All of the best contact ways for Health InfoNet, that's all on the cheat sheet too. So as well as the dates that things are due by and things like that. We have another question in the Q&A. How many meetings does a quality champion need to attend their value-based payment for their center? Will there be a centralized calendar for all QuEST meetings?
Yeah. So there will be a centralized calendar for all QuEST meetings. Yes. And I think we are going to post that on a main care website as well as, again, like Amanda and the team will send out invites and reminders and all these things, but there will be a centralized calendar. And if anything changes in the calendar, we will give notice to that change, but also through email as well. That's why it's nice for us to have a quality contact, but we will be making these things public for other people to see the events as well. So there'll be both ways to find out about these events. And then, so I think, so again, just so you know, when the department has a rule proposed, we don't get into the details of like discussing the rule back and forth with providers or any party external. It's just one of those rules that we have to follow. So what I will say as far as your question regarding participation requirements, when we talk about participation requirements to qualify for the quality bonus pool, you'll see in the proposed rule, the way that that's going to play out is really talking about participation requirements being 7 hours but before October 1st. That is because the rule is a literal, rulemaking document talking about when that rule is adopted, how many hours will be required for you to qualify for the quality bonus pool. That's the requirement. What we're also talking about today is that we are going to offer events starting right now with this event through the whole year and through the next year. So we think it's of value to participate starting now in these events, and it's a lot of good resources shared, but the actual requirement, which is in the rule, is what will qualify you for payment, is the 7 hours before October 1.
If there's any follow-up questions when one of the presenters answers a question, please don't hesitate to jump in. You can also raise your hand, your virtual hand, to ask questions, and we can always call on you. But I see another one in the chat. Will we be provided what portion of the quality bonuses we could have received with metrics expected? Maximum amount to earn, in parentheses. How much we did receive and what metrics we achieved, and what we did not earn a certain amount each year. Maybe a summary or a report for what each entity received in detail. Brooke, I think that's a good one for you.
I do see that Olivia went off.
Yeah.
Sorry, Olivia.
Some of the answers here. So I think that was a great feedback. There's elements of that which are in our report design that we're creating right now, but other elements that are not. So we'll take that feedback, and I agree with you. Certainly at the point when you receive a distribution of the quality bonus pool, which is only once per year, that type of information absolutely would be included. I think a good point though, what you're making, which we'll take back, is even in the quarterly reports to try to give you some sense of what that could qualify you for would be interesting. It gets a little bit wonky because the pool is always going to be distributed in full, which means that the amount of money that any one facility gets is tied to how many other facilities also are accessing the pool. So there will be caveats to any kind of our ability to kind of share with you the range of what you could be expecting to receive, but we're certainly going to show you where are you comparing to national benchmarks. Are you meeting the minimum? Are you meeting the higher standards? Those will be clear. When you translate it into how much money does that mean for you, that gets a little bit murkier, but we'll take it back to see if we can incorporate that somehow. And
Okay.
Brooke, you can feel free to add to that if you want to.
Nope, this would reflect the same, where it is a little bit more speculative for the quarterly reports. So that one is a little bit tricky, but I do think it's something that I want to look into. I think it's a great idea.
Just to give you an idea though, I mean, it's $8.1 million among 78 nursing facilities per year. So it's not like $100 bonus. It's sizable. It's definitely worth, especially the first year is just participation. And it's all stuff that's great to participate in anyway. The next question I have, did you say something about a cheat sheet with information? Where do we get this cheat sheet? So that's in the final stages of development and approval right now. It's basically done. We're hoping to be able to share that by next week. I think that will be very valuable. So we'll not only post it on our rate reform site, but we can definitely send an e-message out about that too, so that folks are aware of it.
I would agree that I think you're going to find it useful. What it does is it condenses a lot of what you heard today in a matrix format. So it's easy to find, what your requirements are.
One page front and back, very succinct. Okay, we've got one more. Oh, we answered that one. Oh, where will these slides be posted? So these will be posted to that rate reform website. And I think that we recently dropped that link in, but maybe we could drop it in one more time. So check out the chat, and that's actually a good page to save to your favorites. Lots and lots of resources there.
Amanda, will we be doing a follow-up via email to this call? I mean, because in addition to putting in the chat, for instance, will we have an opportunity to give people the links in an email or other correspondence?
Sure, I don't see why not. We can definitely have an email and or an OMS message. At some point, the goal would be that everybody would be on our email list, which is quite comprehensive right now, so that we don't have to burden the folks, your business office managers, that don't necessarily want to know about every QuEST email and things like that. So if you're an administrator or a director of nursing and you got this, from somebody else shared with you, you can also email that odes.nifquality@maine.gov to be added to the list too. But yeah, we can certainly send out a summary, as well as we'll post the recording in the PowerPoint.
Right. I think just to get people oriented to where to go for information, because I'm sure everybody agrees you don't want to be bombarded with email either. So we'll hopefully over time, people will just know where to go to get the current information.
I wanted to add, because the rate reform website, it gets updated every year. We post our new rate determination schedule. And as things are completed, we do move them down to prior rate determinations, completed to date. And so I just want people to be aware that when they go to the website, if it's not where it normally was, it'll be further down. It'll literally be copy pasted. All the links will still be there. They should all still work. But just in case you go there, and I've left it there for now because I know there's a lot of information. Everybody's going there. So I'm not going to do anything with it for a while, but maybe in the next couple of months, I'll move it down.
That's actually great foreshadowing, Mandy, because it's a great place for it all to live right now. But as we move forward with these initiatives, we'll have a longer term plan that's very user friendly, where you can access all of the documents, the recordings, the presentations, all of that. So we'll likely be building a SharePoint in the upcoming weeks and months too. We have a quiet bunch. Who else has a question?
I
Okay,
see one in the chat here, and actually it's going to jump in on this. When we were talking about the $8.1 million pool a minute ago, will it be divided equally among homes? No, it's going to be based on your Medicaid bed days. And so the more Medicaid business you do, the higher share you will qualify for. And that's another one of the wonky things that Olivia was referencing. Your Medicaid bed days changes from day to day and month to month. So.
Does anybody have any other questions or possibly seeking clarification on a question that we already answered? Can more than one person from a nursing home be on your email list, or do you prefer only the champion? That is an excellent question. What we built first was just the director of nursing and administrator, but we definitely want your quality champion also. If it gets much beyond 3, that makes it a little bit more challenging, but we'll figure out a way. If you've got 6 people you want to be on it, great. Maybe you won't be able to have all 6 people every time, but what we mostly want is consistent participation from one individual, and that's why they're called the quality champion. Sometimes your director of nursing is going to be able to tune in. Sometimes your administrator is going to be able to tune in. Other times they may have to go and check out the recording, or catch up with the quality champion to hear what the high points were and what they missed. So yes, you can have multiple people on that list. That's no problem at all. We recognize there also may be times, if your quality champion has a vacation scheduled 6 months in advance, we don't expect them to tune in from Bermuda. Occasionally, you may have to designate a backup, right? So if you want to tell us, in advance before that call, who your backup is, so that we can still capture it and give you credit for it. But what we don't want is like a revolving door of this month it's your social worker, and next month it's your director of nursing, and then it's your activities director, because then you kind of lose the cadence and like the building that everybody's doing on that foundation. Other questions? Very good questions. I'll open it up to the presenters. Is there anything else that you wanted to share that we didn't already hit on? while we're waiting for more questions to come in.
I just want to thank you again for coming. It's great to see such a sizable group here. We know that you all care about quality as we do, and it will definitely take a group effort here for us to improve the quality in Maine's nursing homes as we continue to sustain those services so that people can have access. Angela and Brenda, I don't know if you'd like to add any closing thoughts.
No, thank you, Paul, for the opportunity to join you. I think your team assembled here today has done a great job laying out the core areas, and of course, everyone wants to know more about years 2 and 3, but we're going to focus on getting up and running for year 1 right now. But we do know that people have those questions, so sit tight. We'll get there, right?
No, and I just think this is a great opportunity. And again, I think the collaboration will make a big difference. And I think also when you look at the acuity of people, of residents that Maine serves, I think it's really appropriate for the increased staffing levels that will be rewarded by facilities. So I look forward to it, and we'll support you in any way we can. So I think it's exciting. So thank you.
Okay. Well, if we don't have any more questions, and I just want to give you all a shout out for showing up today. I know that everybody on this call is really committed to quality, whether you work directly in a facility or you're one of the supporting organizers. We really appreciate you being here, and we're excited for the opportunity to work with you and partner. Chelsea, do you want to lead us out?
Yeah, so as many of the presenters have already said, thank you all for coming today. After this call, if you have any questions related to the VP program, QuEST calls, if there was any questions we weren't able to get to today, or if you think of down the road, please send them to the odes.nifquality@maine.gov. You can also reach out to Maine Healthcare Organization, and don't forget to please check the rate reform website for today's video. As well as the PowerPoint. Both will be posted, we're hoping, by the end of this week.
Thank you, everybody.
Thank you.